Friends, welcome to the Medical Talk Show. I'm Dr. Nick Coatsworth, and today we're going to get through a whole heap of issues affecting Australians with regard to their healthcare system. Now, I haven't seen this much focus on healthcare in my career as a doctor, and I think that's a good thing. I think it's something we should expect coming out of the pandemic. You know, COVID-19 exposed so many fault lines in our healthcare system, things that we need to repair really so that we can continue to get world-leading healthcare. And, you know, it's my view that we have a really good system, but there's things that we are putting at risk unless we act now. And those things would include affordability of care, access to care when we need it, equity, and particularly equity between rural and regional Australia, and also between Indigenous Australians and who have such differences in life expectancy. So we need to cover off on all those things and actually change our system so that those things are improved and so that they don't cause us problems into the future. So what are some of these things that we've been talking about over the past few weeks? Well, you might have seen that during the pandemic, Aussies accessed their superannuation to pay for elective surgery. Now, that is a real problem as far as I'm concerned. And of course, the reason they did that was because if they paid for their surgery, they could get off the public waiting lists, and a lot of elective surgery shut down during the pandemic, and then move into the private system. So these were people without private health insurance. They would go off into the private system, but then they'd take tens of thousands of dollars out of their superannuation to pay for that surgery. Now, that raises a whole heap of issues. It raises issues about our public hospital elective surgery waiting lists, number one. Number two, for me, it raises the issue of why are surgeons recommending that a patient take money out of their super to go to a private hospital? Surely if you're a surgeon in that situation, you pick up the phone to the public hospital and say, listen, I need Mr. or Mrs. Smith to be operated on a little bit quicker. Let's sort out them on the waiting list and bump them up a little bit. I'm not sure I could sleep at night if I knew that I was telling someone to access their super and then some of that money was coming to me. I think that's problematic. Unfortunately, I called the ex-president of the Royal Australasian College of Surgeons about this only a couple of days ago, and he confirmed that it is not the position of the Royal Australian College that surgeons recommend people to go into their super. But it does mean that we have to do something about the elective surgery waiting list. And also as patients, we need to understand the options that are available to us with elective surgery. You know, a surgeon will most often recommend surgery. That's what they do. Physicians like me often recommend against surgery. And when we do that for people with hip or knee or back problems, often we recommend allied health professionals to help strengthen the muscles around a joint and so on and so forth. And, you know, I'm not saying that everybody on an elective list can avoid surgery in the end, but there's certainly a lot you can do in the meantime, particularly with physiotherapy, that's going to help you. So there's three things there. Number one, we need to help public hospitals become more efficient so they can get through their waiting list. That's important. There's a whole heap of issues around that. Number two, don't access your super to pay for surgery. That's just a bad idea, I think. And number three, there are cheaper alternatives when you're on the elective list to make sure that your life is better, and that includes physiotherapy. Although, of course, I acknowledge that that's not cheap either. It probably costs about $140 for an initial physio consult and $90 for a follow-up, and some of that, if you're lucky to have private health insurance, is of course covered there. So the health system, this is a good example of one of the things that we have to sort out in our health system so it remains affordable and equitable. But, you know, we have to also remember that things aren't all that bad and things are relative. And one of the things I do want to talk about today was the earthquake in Turkey. Now, that's been one of the major humanitarian disasters. It makes us realise when we're concerned about healthcare in Australia that there are a lot worse things going on in the world at the moment. And if you do have a little bit of spare money to spend or to offer in assistance, then there are great organisations like Médecins Sans Frontières, the Red Cross, United Nations, all of whom would benefit from a little bit of funding. But a few statistics there just to remind ourselves just how bad this is. Upwards of 10,000 people have lost their lives. That means that there's millions of people displaced in northern Syria and Turkey. And did you know that in northern Syria, there were already 4.1 million people dependent on humanitarian aid? That means that they were dependent on external aid for food, water, sanitation and shelter. And that was before the earthquake. This is occurring in winter. And so people who did survive not only have to contend with losing their family members, searching for their family members, but also contend with the fact that they're in freezing sub-zero conditions without shelter. This is a major issue. And I think, in my career in humanitarian medicine, as you know, I've been away to Africa mainly with Médecins Sans Frontières. I do reckon there's been a decrease and narrowing in global consciousness about these sort of issues. We're a lot more focused on what happens to ourselves, us as individuals, our lives in our own country. And I think it's important as a global community that we just remember that there are people in very, very precarious health systems out there. If we do have the opportunity to help, we absolutely should. It's all about keeping a degree of perspective, and that perspective is kind of healthy when we're going through life and going through our own trials and tribulations. Speaking of perspective, got a lot of perspectives in the past 24 hours from people on my Facebook page, the ATAGI group, who they make the decisions about our immunisation for COVID-19, recently brought out a recommendation suggesting that over 65s should have a fifth booster dose. Now, I wholeheartedly endorse that. I think that's a really important thing for over 65s. COVID, of course, affects the elderly much more than people who are younger. That dose is available for people over the age of 18 if they want it, and for people under the age of 18, we're not recommending it. Now, I went on the Today Show with old Karl Stefanovic, who made a pretty blunt comment that he was only a 2 or a 3 dose guy. I wasn't quite sure which, 2 or 3 doses, Karl, but anyway. And that provoked quite a vigorous response when I said that the mRNA vaccines were both safe and effective. And I do believe that they're safe and effective. I think that safety doesn't mean they're without complications, and we know that there's complications from mRNA vaccines with heart inflammation. We've got a good monitoring system with our TGA, but my Facebook page was really flooded with comments about really from anti-vaxxers and people suggesting that doctors who were saying that the vaccine was safe had blood on their hands and should go on another Nuremberg trial. Now, for those of you that don't know what Nuremberg is, Nuremberg was the trial of the Nazis after World War II. And that was obviously a vastly different situation to doctors recommending that you get vaccinated. So it's really interesting psychologically from my point of view. I don't think I actually had that in 2021 and 2022, even though I was, up in front of the nation on the adverts. It actually seems to be a little bit worse now that we're talking fifth dose and we're talking at the end of the COVID pandemic. Suddenly we're getting all this negative social media feedback. And at least for 24 hours, I was looking at this going, oh, gee, maybe people really are more concerned about this, and maybe there are a lot more vaccine injuries going on. And it was really interesting personally to experience that, because that's an example of how social media can amplify things and distort perspective. To combat that, we really need to have faith in our institutions like the TGA, who do the vaccine safety monitoring. They're not perfect, the TGA. It's possible that some deaths have been misclassified as not due to the vaccine when they were. That's entirely possible, and we should admit that. But I can guarantee that we're not talking about hundreds of thousands or even hundreds, or probably even in the tens. It might just be a handful. And that's going to be a controversial opinion for some, but not for most. I think most people in Australia understand that. And one of the great things about being Australian in the Australian healthcare system and the Australian community is we are not as polarised as some nations like the United States. So I just wanted to thank everyone who put those posts on. They've all been deleted now because I'm all for freedom of speech, but I don't like being compared to Nazis. And I don't think that's fair on the health professionals who are out there trying to do their best interpreting the science. It's not just me. There's obviously a whole heap of others out there who take the same sort of position as I do in promoting vaccination, and we will continue to to do so. Now, whilst it's important that we all have our voice on social media, I think there's a really important voice that we're debating at the moment, and that is the voice of Indigenous peoples in our Constitution. And I wanted to make it clear where my position is on this. I think that we should be voting yes when the referendum comes up later on in the year. Why do I think that? Well, as you know, I've been up in Darwin and we were there for 3.5 years. 2 of my 3 kids were actually born in the Northern Territory. So I've seen firsthand the gap in healthcare that Indigenous Australians have compared to non-Indigenous Australians. And that's manifest in a vastly different life expectancy for Indigenous men and women, which is far lower than that of their non-Indigenous counterparts. We have the highest rate of rheumatic heart disease in the world. Rheumatic heart disease is a condition of deprivation and poverty, and it occurs when people are living in very close quarters in conditions that are unsatisfactory. And then a very common bacteria called Group A streptococcus, which gives skin sores. People will be aware of those from when their kids were at school. Then that actually causes their heart valves to be attacked with rheumatic heart disease. And, people in their teens end up with chronic heart failure. And so there's a lot of young Indigenous Australians with heart failure from rheumatic heart disease. And that's just one example of the poorer health outcomes. Now, one of the things I've been a bit frustrated with is that our politicians, mainly the politicians that are for the Voice, have been unable to explain why the Voice is going to change these things. So I wanted to give it a crack because I think explaining why a Voice is going to improve healthcare is a really important reason to vote for it. And I hope I'm giving Albo a bit of a hand here when I'm doing this. A lot of the problems, at least as I see it, and this is the thing, another thing, because I'm non-Indigenous, you've got to take that into account when I'm giving an opinion. I've seen Indigenous healthcare, I'm non-Indigenous. You've got to weight that in terms of what I'm saying, but I'm going to give you an opinion because I think I've seen enough. A lot of the poor health outcomes are also due to broader issues than health. We're talking about education. We're talking about alcohol and drug use. We're talking about generational trauma and the stolen generations. And we're talking about dispossession. Now, a lot of Australians don't like to hear those words, but the reality is that it's only 200 years ago, just over, that Australia was, and it was from the perspective of the Indigenous Australia, invaded, colonised from the perspective of non-Indigenous Australians. Doesn't really matter what you call it, but that's not long ago. And so those effects are persistent across Australian society today, and they do have an effect on people's healthcare. Because if you experience racism, if you sense constantly that people are undermining you and you don't have that sense of pride in who you are and you don't feel part of Australia, that's going to affect your health. And I think that a voice to Parliament, an Indigenous voice to Parliament, is going to affect the way that Australians interact, Indigenous and non-Indigenous. It is going to affect the pride that Indigenous Australians feel coming from other non-Indigenous Australians. It's going to improve that, and it's going to improve healthcare. So that's why I'm going to vote yes. You know who I'm not as eloquent as? I'm not as eloquent as Noel Pearson, who's an Indigenous leader in Australia, and he actually spoke to this in the first Boyer lecture last year on the ABC. Now, some people watching this will never watch the ABC, and I would implore you to get online and watch Noel Pearson do that talk. It's only about 30 minutes. We've got the address for you below. Go to the URL, have a listen to what Noel Pearson says, and I guarantee you'll be hard-pressed not to be convinced to vote yes. And it's not just about voting yes, because I think it will actually pass. But remember in 1967, we had another referendum about Indigenous Australians, and that passed with 9 out of 10 people voting yes. So I don't want to see 55% or even 65%. I'd like to see well in excess of 75% of Australians across all age groups voting yes, because I think it's going to have a big impact on the healthcare of Indigenous Australians. Now, the start of 2023 in Australia has been characterised by a discussion on our health system that really I haven't seen in my medical career. And I reckon that's a really good thing, because whilst we have a good health system, there are things that we do need to improve. There's been a focus on general practice, and as you'll remember from the last episode, general practitioners are your specialists in life. That was a campaign by the Royal Australasian College of General Practitioners a few years ago. General practice is a specialty. There's no such thing as just a GP, and in my view, general practice must remain at the core of what we call primary healthcare in Australia. But there's a lot of changes that have happened over the past 30 years to the way we deliver that primary care, including an increase in the number of Australians that have chronic disease and an ageing population. And that's going to necessitate a change in how we as doctors and consumers interact and how we deliver primary care. Now, I'm not a primary care specialist. I'm a physician and I do respiratory and infectious diseases. So we need someone who's going to unpack all this for us. And I've got my close colleague in Canberra, general practitioner Paresh Dowda, here with us today. Paresh, thanks so much for your time joining us.
Thank you. It's a pleasure, Nick. Thank you for inviting me.
Now, Paresh, you heard the intro and we've heard that in the media that people can't get to see a GP, that there's waiting times. People are on social media saying they don't like having to go for referrals or simple scripts and things like that. And perhaps most importantly, that there's a shortage of GPs in Australia. Just how bad are things for general practice at the moment?
Yeah, look, Nick, there's no doubt that I think there's stress in the system. I think there's stress for a whole bunch of reasons, but the way that's manifesting itself is certainly perhaps longer waits for people to be seen. I think there's a cost issue in relation to general practice as well. Again, for various reasons, but it's becoming often an unspoken elephant in the room is, should general practice be free at the point of delivery? And bulk billing's our kind of proxy around that. And I think there's been tensions around that because of increasing costs of living, but Medicare rebates perhaps not keeping pace with that, creating, general practices are essentially small businesses, and that's created a tension. And so, some members of the public are now finding it's not free at the point of delivery. And of course, that's adding to the cost of living pressures for society.
I reckon that's a really interesting point. And as you say, it's an elephant in the room. No one's really discussed it. We've had decades of people saying that we've got this system where for general practice is essentially free, and that we almost define success by the number of people who are being bulk billed. And of course, bulk billing actually means you don't have to pay anything. Medicare pays it all for you. Now there's these gaps. Let's answer the question, should general practice be free at the point of care?
So I think we almost need to take a step back to answer that question, right? So, I think the question is, why is general practice so important?
Yeah.
And general practice is a bit like a black box, Things happen within the realm of general practice which are perhaps more difficult to dissect and break up compared to other parts of medicine. But what the research tells us is actually countries that have a strong primary care foundation actually deliver care more effectively and more efficiently. So it's kind of a win-win to have a strong general practice system. Countries that don't have that have poorer outcomes and are more expensive. So, without a doubt, I think there's benefit in strengthening general practice and having a strong primary care system. The challenge, I guess, around this is, should that be free at the point of care? We know, again, from research evidence, where general practice works well, it helps prevention. There's actually now really good research to say it actually reduces deaths.
Reduces deaths?
So we have less mortality where we've got continuity of care and relational approach to general practice. But more importantly, I think, is it addresses the equity issue. So, long-standing in healthcare has been this inverse care law, which says people in most need of healthcare are least likely to get that.
And least likely to afford it.
And least likely to afford it. So that's the sort of inverse care law, first talked about, I think, in the 1950s, I think it was.
Wow. So we've
by
known
Welsh GP.
Yeah, we've known about it for a long time.
So we've known about it for a long time. But what we know is where we've got, again, strong primary care foundations, it helps address that equity issue as well. It doesn't solve it, but it helps address it. And it's better than when we don't have a primary care system.
So how can there be equity if someone's got to pay an $80 gap or a $40 out-of-pocket cost, something like that?
I think that's the big policy question now, isn't it? Is the tension between people having to pay for their primary care versus the benefits you get from general practice. They've it feels like they've gone past that sweet spot.
Yeah.
And that's what's, I think, causing the tension and the stress in the system now.
So, I mean, you've spoken a lot about the benefits of primary care, but I think it's fair to say that, there's been this erosion over the past 20 years of general practice and primary care. And when you hear that, a lot of time you're hearing that from the GP leadership. Have GPs not been able to sell their core value proposition to the Australian public?
So look, again, I think that's a really interesting question. And certainly I think within the primary care sector, my colleagues, there's always a question around, how do we demonstrate the value of general practice? Again, when you've got a black box and it's hard to dissect out what happens within that black box, it becomes something that's harder to measure. If we're looking at a knee operation or a hip operation, it's very discrete activity.
Or numbers of beds in hospital, emergency department waiting times, those sort of things.
We can measure that. I think when we're talking about general practice, it's not episodic care. It's not discrete activities. It's activity over one's lifetime.
Over a lifetime, yeah.
It's longitudinal. It's relational. And so there are no simple measures for that sort of care, which means the ability to demonstrate value from simple measurement is hard. And so I think that's been one of the challenges, I think, around that.
How would you tell a consumer now, a patient now? I mean, it all sounds good to me, but I'm a doctor. I was trained in the value of general practice. We get taught that in medical school. We understand it. But, do you agree that patients no longer see that value in the same way? And how can we change it?
Look, I actually feel that most patients do see the value in general practice. I think particularly patients who've got longer-term conditions, chronic conditions, who need to access care frequently. I think they see that value. The amount of times I have patients come back to see me after they might have seen a specialist to discuss whether the intervention recommended by the specialist is appropriate or not, it's really quite fascinating. I think what that tells me is consumers and patients have a lot of trust in their GP, is their trusted partner who walks along with them in the healthcare journey. So I think that there is certainly value in that. However, as society, I think we've also moved along, haven't we? There's a great deal more consumerism in all other aspects of our life. Things are done much more online, much more instant, much more responsive, much more quicker than perhaps healthcare is. And so I think there's almost this dissonance between how things happen in all other aspects of our life and what happens in our general practice access to care. You started off today with the introduction around, things have changed since Medicare was introduced. The system hasn't really kept pace with the societal trends and changes and the way the demographics have changed and the illnesses people now have. And so we're working with a system that's 30, 40 plus years out of date, no longer really fit for purpose. And we're trying to make it work. And I think that's what's manifesting in consumers' voicing of, some of the things that they're forced to do, but feel like it's no longer appropriate.
So this frustration that consumers are demonstrating. And I think, I heard some journalists last week, in fact, Deborah Knight on 2GB asked me the question, look, if I want a skin cancer check from a dermatologist, why should I go to my general practitioner? Why can't I go straight to a specialist? Why not? Why do you go to your GP first to get referrals?
Yeah, the great question. And at the beginning, I think I sort of mentioned one of the benefits of a strong primary healthcare system is effectiveness and efficiency. One of the things we do know about the black box is general practice is a gateway to the rest of the health system. Mm-hmm. Some people talk about it as a gatekeeper. I like to think about it as a gateway.
Yes.
I think when people come to a general practitioner around a referral to a specialist, it's not really necessarily about the condition that they're presented with. Of course, it's about that, but it's about looking at the appropriateness of that. It's about looking at other aspects, other aspects such as the prevention that I was talking about earlier. So actually what happens within that black box is a lot more than the symptom or the condition somebody feels they may have or the clinical need that they feel they may have. And each one of those touch points is about also building that longitudinal relationship, right? Yeah. It's about creating the trust. It's about creating the empathy, about the compassion, the collaboration. So I think for all those reasons, it's important that people do go to see their GP because it allows our system to be effective and efficient.
And I suppose the other way to think about it is the counterfactual. I mean, what would actually happen if we didn't have GPs? I mean, who would coordinate the care and who would have that brilliant skill that general practitioners have of actually being able to pick when there's something wrong with a patient that they don't even know that they have. Can you imagine a system without GPs?
Look, I can't because I've always lived and worked in a system where there's been strong primary care. I sometimes think about general practice as a bit of a dynamic non-event. So when it's there, when it's there and it works and it functions, things just happen and people perhaps don't appreciate it. Where people really appreciate it is when it disappears, because then it becomes much more apparent, much more noticeable. And we see that in countries around the world where there isn't a primary healthcare system. They've got poorer health outcomes. It's more costly. There's not equity. So people in most need of care are the least likely to receive it.
Yeah. And I mean, that really resonates with me. I saw some patients from Young, which for those around Australia who don't know where Young is, it's a country town just north of the ACT. I've got to check my geography. But this was really interesting. This is a couple who had lived there, been farmers for 60 years. And they said that they'd never imagined a time where they wouldn't have the same general practitioner. And yet they'd now had over the past few years rotating general practitioners, and they were facing a situation where now they don't have a general practitioner. What are we going to do? I mean, this is like 2.5, 3 hours north of Canberra, if that. What are we going to do to support patients like that? How are we going to get them GPs?
There's no doubt there's a workforce crisis. We've probably got the least number of medical graduates wanting to choosing general practice as a career of choice. But also, I think we've got to go back to the where general practice has come from, and how we operate and work with general practice. So, if you look at Australia, for example, for maybe every 900,000 people, head of population, we might have one GP. We look at countries like the UK, it might be more 1,800 people to one head of GP.
So our ratio is more favourable in Australia.
So
we've got more GPs.
It is more favourable on the face of it. We go to some of the more developed health systems within the US. The US is complex. In the more developed health systems in the US, the ratio might be closer to 2,800, 3,000. Patients to one GP. Now, the big difference there is in those systems, other members of the health team help the GPs, support the GPs. So nurses are more involved, maybe non-dispensing pharmacists, maybe allied health, psychologists are part of that core team that support the the delivery. In Australia, our system doesn't facilitate that.
And is that because of this bulk billing fee for service? Is that why the funding system doesn't facilitate it?
Well, not so much about the fact that it's not so much about the bulk billing aspect. Mm-hmm. It's much more about the work. When our Medicare system was designed, it was designed with episodic care in mind. Mm-hmm. So, you might have a chest infection or a sprained ankle. Mm. You go in, get that dealt with, and there's a rebate for that activity.
Yep.
In your intro, you said it earlier, now we've got people with many more long-term conditions, chronic diseases. People have more than one condition, so we've got multi-morbidity. That episodic approach doesn't really work for that. Yet our funding system is tied to every time you see a GP is when somebody gets a rebate.
Yeah.
If they see a nurse, there's no real rebate available for that. If they see a pharmacist within the practice, there's no rebate available for that.
So basically the practice is covering, if the practice wants to have multidisciplinary care under the system we've got at the moment, you can only take that rebate plus whatever else the practice charges the patient. That's got to fund everything else.
Absolutely.
So that doesn't sound like enough.
It's not, and that's why we're seeing the tensions we are in the system at the moment.
So, the Strengthening Medicare Task Force, which, I hope all Australians have heard about, but I suspect many of them haven't, released a report recently, and it talked about multidisciplinary, integrated and blended care. I read the report. I'm not sure it was very consumable. Help us understand, what are those beyond just buzzwords in general practice?
Yeah, so look, I'm going to respond to that at two levels. So firstly, I'm going to respond to it as at the level of, what do we mean by a person-centred healthcare system?
People use that word so often.
People use it all the time,
yeah.
Right? We've thought about this a lot in our practice, mm-hmm. and we've used a very sort of simple definition around this. So, it's care that's individualised. So it's not a cookie-cutter approach. It's an individualised care plan. It's about care that's enabling. So again, we know that if we can help people to better look after themselves, we get better outcomes. So that's what I mean by enabling care.
Yep.
It's about care that's coordinated. So we now know, with people having more and more chronic conditions that we talked about earlier, the one person providing all that care is no longer feasible. It's no longer possible. It needs a team. That team needs coordination. So coordination of that care is part of person-centred care. And I think the fourth component really is around the relational aspects. It's about respectful care. It's about compassionate care. So I think that's what we mean by person-centred care system.
And that, I know you've got another point to come after this, but that all sounds brilliant from where I'm sitting. But I guess one of my observations, and I've got to be careful, I'm not a general practitioner, I'm a physician, and within medicine, people, there's even clear professional boundaries, and I'm certainly not trying to lecture general practice. But it's not as though we haven't seen all this coming. People didn't just start to age in 2023. And your practice has come up with this, but why isn't this sort of a global sort of perspective of all general practitioners? And how much does the general practice leadership have to blame for not bringing general practice into 2023? Yeah. I know it's a loaded question, but I need a loaded answer.
Yeah, well, I'm going to disappoint you, Nick, because I haven't got a loaded answer. But as you know, my kind of expertise really, it comes from the quality and safety world, healthcare quality and patient safety. Now, one of the things in that paradigm that is really helpful, I think, to help us think about this is, whenever there's a care delivery problem, let's say, something unintended happens to a patient,
yes,
the health systems always kind of looked at the person who's responsible for that care delivery and pointed the finger at that level.
Yep.
Over the last 2 decades, what we've learned is actually that's the active failure, sure, but we need to look beyond that. We need to look at, the conditions that led to that error happening.
Yep.
That could be about teamwork, it could be about patient factors, it could be the actual task factors, so a whole bunch of error-producing conditions. But if we ask the question why, again, it actually takes us to what I call latent failures.
Right.
So this is about culture,
Yes.
it's about leadership, it's about resources, it's about finances. So that's how we look at patient safety. We can actually use, I think, the same construct to think about the very question you just asked me. We've seen this problem coming for 20 years. Why has nothing been done about it? Well, I think we haven't really gone, and your loaded question to me was, is it the responsibility of GPs and the active failure? I would argue it's not. It's a latent failure.
Yeah.
It's a culture of the system. It's a resourcing of the system. It's the cross-sectorial and global sort of leadership around this that's failed.
Although there's cultures there's microcultures within medicine,
Yeah.
and I guess one of the observations that I would make is that winners are grinners, and we've got to get to the point where if so few medical graduates are doing general practice, we got to try and talk general practice up a bit more, and I think that there are contrasting campaigns that you'll remember well. There was the Not Just a GP campaign, which it jars a little bit because it focuses on that idea of just being a GP. It was like another bloody Volvo driver campaign that fell really, really flat. And then there was the Specialist in Life campaign. And that was a much better campaign because it really defined what general practice is about. Now, contrast that with, say, anaesthetists who are constantly banging on about how great they are, which I would contest, by the way, and I think the general practitioners are much more important to our healthcare system. But they end up with a far different sort of perspective about who they are and what culture they have. So maybe there is a cultural element to this within general practice. We need to give them all a rev up a bit, and this is the place you want to be. You want to be in general practice.
Yeah, and look, I think there's certainly the GP leadership. I think has to an extent risen to that challenge. So I think there's certainly a great deal more vocalism around this. There's a lot more campaigning around this, lobbying around this. So I think there has been a rise to that challenge. I think the other thing I'd say around this, Nick, also is it's not that over the last 20 years things haven't been done or tried. If I think back over the last 20 years, there have been various initiatives, trials, pilots. There's a coordinated care trials. There's a diabetes pilot in, I think, 2008, 2009. There's healthcare homes initiative from the Commonwealth Government 4 or 5 years ago. There have been things that have been looked at and tried. But again, I think we're kind of in this paradigm of pilotitis.
That's a good one. Yeah.
So, we do lots of little pilots. We tied into political cycles, governments change, and that goes on a shelf somewhere.
Absolutely.
And someone reinvents the wheel.
Yeah.
I think the time's come to say, actually, we really need change. Let's get away from the pilotitis mentality. Let's go with, we just need something good enough.
Yep.
Start there, and let's do it at scale, but let's iterate very quickly. So that's frugal innovation.
And you're putting blocks on building a structure instead of just sticking one brick down and one brick over somewhere else. And,
Absolutely.
And that sort of thing. Paresh, one of the things that I guess we were always taught in medical school, that there is an art to general practice. And although I've said on this show that I think it's worth trialling things like autonomous pharmacist prescribing and nurse practitioners might be given a deeper role, there is no substitute, in my view, to the art of seeing 30 or 40 patients a day with primary care ailments largely, and then having to pick the one of those that is actually really crook and has an underlying cancer that they don't know about. What do we do to ignite the passion in medical students for that? Because for me, I just find that absolutely brilliant and something that we should admire amongst our GP colleagues.
So, if I reflect on my general practice career, it's been enormously professionally satisfying. I think where perhaps things become a bit of a challenge are, the nature of it is people are often siloed in their rooms. So you might be in a group practice, but you're in their rooms. And, I think what you're alluding to there is, do we let other members of the healthcare team, like pharmacists, prescribe, for example? I've been involved, although in another country, in training pharmacists to prescribe. So that kind of tells you a bit about where I come from.
Yeah.
In that same country, we also had a system of very much a team-based approach. So I'll give you an example. I think this will kind of crystallize this for us. So in the practice I worked in, we created an unscheduled care service. So this was people who needed same-day appointments, things like urine infections, ear infections, the very sort of thing we're trialing pharmacists prescribing for in Australia at the moment. But what we did in that system was we actually had a team. So we had nurses, we had a pharmacist, we had a GP, all together providing that unscheduled care service. So when that patient rang or came in and they were seen by the pharmacist, if there was a concern, the GP was next door or the nurse was next door. So it was collectively a greater skills mix at the point of care delivery. That's got an enormous amount of professional satisfaction around that. So I think that can become an attractor for future medical graduates. I'm going to talk about the dollars, just to mention it, because I think intrinsic motivation is really important.
Yep.
And there's a big part of this around, those who do general practice being intrinsically motivated. But there's also a big differential, for example, between what a general practitioner might earn and what a specialist might earn. And it can be tens of thousands of dollars difference.
Let's be clear, it can be hundreds of thousands. You can stick an extra zero on my salary to get to what anaesthetists and ophthalmologists and people are earning.
Absolutely.
How corrosive is that, do you think?
Well, look, I think it's incredibly corrosive. And I think, the issue is when people go through their training, particularly as an undergraduate, whether you want to be a GP or a surgeon, you incur the same costs, you incur the same debt.
Yep.
And so naturally people come out at the end of their training with a deficit they've got to pay off. And I think that's perhaps a driver in all of this as well. Equity and recognition of the skills general practice bring, I think is really, really important.
Absolutely.
For far too long, I think medicine has rewarded procedural work far greater than non-procedural work. Yet I would argue some of the non-procedural work is of more value to society and, public value than some of the procedural work. And maybe that's something we need to be questioning and talking about.
Paresh, I reckon that's a great way to bring things to a close. You said two brilliant things there, which are we are stronger together. If we are nurses, pharmacists or general practitioners, if we work apart, then we're not going to be as strong as the sum of our parts together. And also, we need to get away from the focus on procedural and diagnostic care. But folks, to do that, we actually need your help as well, because there is a consumer expectation to get procedures, to get diagnosis, and that also drives what we're talking about here, a move towards high-level expensive care and away from the sort of quality care that Paresh and his colleagues provide in general practice around Australia. We're going to leave it there. Make sure if you've enjoyed today, if you've learnt a lot, subscribe on our YouTube channel and wherever you get your podcasts. Paresh Dowda, thank you so much.
Thank you, Nick.